Welcome, everyone, once again to our narrow roundtable, part of Venus Edge. And again, when we mean roundtable and it's narrow, we mean we're going to focus on one particular question that you may have thought about or you want answered. And the question this evening with our panel of experts is, we're going to discuss acute DVT, when to intervene and when not to intervene. And that's all we're going to stick to. When you decide, I got to do something more than just anticoagulate the patient. With us today is Tino Pena from Miami Vascular. He is an interventional radiologist. And we have Chris Huff from Ohio Health, who is both interventional cardiologist and a vascular medicine physician. Ron Winokur from Jefferson University in Philly. He's an interventional radiologist. And rounding out our panel is Kelly Brown from Medical College of Wisconsin in Milwaukee. So here we go. Here's the scenario. What do we need to think about? You get called, you're either in your office, you're at home or whatever, from someone in the ED department. I have somebody here with a iliofemoral DVT. All right, Ron, what's going through your head when they call you? What are the things you need to know when you're going to make your decision, what you may need to do?
I think the first thing we need to know is a lot more about the history, duration of symptoms, when did the thrombus occur, the central extent of the thrombus, and what other history there might be in that patient. If they have prior history of DVT, do they have a filter in place? Have they had other interventions or stenting beforehand? What their current treatment strategy is as far as anticoagulation, and do they have any other symptoms? Are they having shortness of breath? Do they have a PE? So that we can start to target treatment strategies.
All right, Chris, did he leave anything out?
Well, I mean, I agree with every one of those. Those are very important questions to ask. I think what determines whether it's emergent or not is whether or not the patient has phlegmasia. That's actually not that common. But to be honest, we see a lot of people with engorged purple swollen legs that aren't truly phlegmatic. And those can usually, wait. They don't have to be done emergently. But if the patient has true phlegmasia and their limb is threatened, that is an emergency and it needs to be treated quickly.
So Kelly, would you say that is the only emergency for someone with acute DVT is real phlegmasia? Not like on the borderline phlegmasia, but like, is there anything else?
Well, for me,
it's not a trick question. I can't think of it myself.
No, I think for me that really is it, aside from PE, which I think can be an emergency depending on how big it is and how symptomatic the patient is. But emergently, middle of the night, take them and do something right away. That's real phlegmasia that you're trying to prevent limb loss. You're trying to restore arterial perfusion and prevent muscle death.
Yeah. So Tina, and I kind of tend to agree with that. So Tino, it's not an emergency now. You've determined it's not an emergency. So do you need to go in to see that person to have yourself at 4:30 in the morning, or what would be your temporizing thing before you're going to come to your final decision? Do I need to intervene or not?
I mean, I think obviously you start the anticoagulation, get an idea of how they're doing on that anticoagulation. I'd like to see, how severe the symptoms are. The leg swelling, is that what brought them in? And one other thing that I really like to look at is the patient ambulatory? Is the patient, what am I trying to, what am I trying to prevent by treating this DVT? If it's post-thrombotic syndrome, I want to find out, is this patient ambulatory? And, what's my chances of doing that? Because sometimes you see a patient, they're not even ambulatory, and they may not be a candidate.
Exactly.
I think that's a great point, because if they're not ambulatory, no matter what you do as far as intervention, you may not have any long-term success of patency.
Right, I agree. And not to mention the potential harm you could cause a patient who's non-ambulatory for no real benefit. The risk of severe bleeding with lytic therapy, the risk of causing pulmonary embolism with mechanical thrombectomy. So that's a great point, All
right, so that goes into really one of the main first questions I was going to ask is, who absolutely who do you not even need to consider intervening on? You said someone maybe who's non-ambulatory. What else? Kelly, who is somebody that like, absolutely, I do not even think about intervening on this person?
Somebody with a major contraindication. So somebody who, can't tolerate either has had a recent head bleed or recent, eye surgery, or, something that's really sort of a really sort of definite contraindication. So you have to do a really thorough history, like everybody was saying earlier, to make sure that you're not putting somebody at significant risk for something that may or may not be a huge benefit depending on their lifestyle and their symptoms.
All right, so let me push you a little bit on that, Kelly, and we're not going to get into therapy, but do you think the decision to intervene has changed a little bit in that we now have nice devices that are
Yeah.
non-thrombolytic mechanical devices?
Yeah, certainly it has. Yeah,
Right. So
absolutely.
we may intervene on someone who really did have recent back surgery, 4
Right,
days.
in a different way. And I think, it's sort of a subtle, this kind of gets into sort of a subtle decision making, because I think it depends on what things look like and what your experience is and what you feel you can take care of without having to go the lytic route.
Right. So Ron, what else is I don't even need to think about this intervening. But let me give you a little bit of hint. What is it in terms of extent of thrombus that you may decide I don't need to intervene?
Yeah, I think differentiating iliofemoral from femoral popliteal disease is an important differentiating point. And if somebody really just has femoral popliteal disease, then that's not going to be somebody who's going to benefit from intervention. And you can pretty much leave that
Right.
aside.
Yeah. So okay, iliofemoral, and obviously anything less than that, infrapopliteal and stuff, you're not going to intervene either. So that's anything that's on the imaging. Anything on the history, Tino, that you would say I absolutely don't need to intervene on the physical exam, Tino? I'm sorry.
For me, it really has to do with symptoms, right? How much better am I going to make if a patient really, they may have a DVT, but really they're not having any symptoms? I'm not going to make them any better. At least I don't think I'm going to make them any better. I question, could I be trying to prevent symptoms in the future in terms of post-traumatic syndrome? But for me, I really, on the physical exam and when I'm talking to them, I'm looking to see the amount of swelling. And a lot of times, I don't see the necessity to treat them immediately, like the acuity of it. I may give them 24 hours if they're in the hospital, see if they get better on anticoagulation. And that may kind of turn the tables on me as to decide to treat or not to treat.
Yeah, so that's good. Oh, so you guys are like, right, I have put some questions down before we even got here, and you guys are answering a lot of them. So Chris, that leads into what Tino just said. When do you decide that you do need to intervene in terms of the time course of the patient? We've already decided, you've told us, intervene, yes. Significant phlegmasia, for sure, you're doing it like right away. But otherwise, what is your time course when you decide I may need to intervene or not? What do you do until you get to that point?
Yeah. So if there's a question regarding potential intervention, it's not someone I would send home and have them come to my office a week later. It's something I'm going to answer while they're in the hospital. And I usually give them close to 24 hours of either IV heparin or Lovenox with leg elevation and compression. It's amazing how many people are hesitant to compress a leg with DVT. They're concerned it's going to cause a pulmonary embolism. And that's just not the case. So we elevate, we compress, we give either Lovenox or heparin, and we recheck the leg the next day. And to Tino's point, if it's better, you're done. I mean, this is not a life-saving procedure. This is a procedure to help their symptoms long-term. And if they're asymptomatic, you're not going to make them better.
And
Right.
frankly, I would say most patients get better.
Well,
I agree.
most patients get better. Let me take you a little bit down the road here, because maybe you're walking down where I wanted you to walk. You said you give them 24 hours, you give them elevation, give them compression and stuff. But nobody lives like that the rest of their life. So I feel it's important, if I can, I know I'm the moderator, but I could also say, I also would add to me, I get the patient up and walking in the hospital for at least half a day, off and on, to see how they feel. And if they say, I'm in bed, I'm feeling great, but when I get up, I can hardly make it to the bathroom. And that will push me, or in the opposite direction. Hey, I was walking the hallways and I'm feeling pretty good. So I do think you need to get them up. Ron, what do you think of that?
I think you have to ambulate them. I think that standing venous pressure is going to be a real test for them as far as their lifestyle performance and what they're going to do when they leave the hospital. So I think it is. I agree. I think you have to give it a little bit of time, give them a trial of walking, a trial of activity. I agree with the compression while in bed. If it's impossible to get them graduated compression socks unless they have them while they're in the hospital, nobody will get them, and TED stockings are kind of useless. But trying to ambulate them and see how they do, I think, is an important question. And then the other point I was going to bring up was timing. As far as you were asking a question, when do you intervene? I think knowing the duration of that thrombus is so important. And obviously inside of 2 weeks, you have a lot more options. As you get longer, that option starts to fade away. And I think there's also a time point in the subacute phase when somebody is at that 3 to 6 week mark where people are starting to use maybe thrombectomy tools a little more often. And you're not going to get good patency in that timeline. I think they have a lot more thrombosis at that time point.
All right, now let me ask you this, because I want to kind of hone down. We've been doing this for about 10 minutes or so. What I'm hearing from all of you is the great majority of the time, the decision to intervene or not is really based upon how the patient is doing, how their symptoms are. Is there any, and Kelly, I'll start with you, is there any anatomic or imaging study or finding that's going to say, I really need to intervene on this patient? I know this is a tough question.
Certainly. So this was already mentioned. Certainly, if it's femoral popliteal, I don't think, that would certainly, I would not intervene on that.
But the other way, is there anything you're going to say on axial imaging or?
I think the other thing that's concerning to me is patients who've had PE in the past. Let's say a recurrent PE and can't tolerate it. You've got to filter in, and the whole thing is clotted all the way to the filter. If they're symptomatic, I mean, that's a problematic situation, but that may push me a little bit. But there's nothing that I can think of. I don't know what exactly you're driving at. If there is something.
What I'm driving at is I want our listeners to take away from this that it's not necessarily what the ultrasound findings and or MR or CT findings are. It's really with how the patient is doing. Unless I'm asking you all, is there a CT or MR finding or whatever that's going to say, I really got to do something here?
Yeah, there's nothing that I can think of that is consistently going to make me intervene based just imaging finding.
Ron is raising his hand.
He's got something. Ron's got something. It'll probably be a good one.
And Kelly, you already mentioned it. If you see free-floating thrombus hanging off the top of an IVC filter, and it looks like it's mobile, and you really need to intervene on that because it may embolize, and especially in somebody with a history of PE who probably their recurrent disease is going to be the same disease that they presented with before, and they're going to come back with PE again. Those would be the things that would probably push me a little from an imaging standpoint. I don't know if Tina, you had something else.
Yeah, I mean, I was going to say, I think this is an important question. As someone who does a vascular imaging, I always hold back on doing imaging until I've made a decision that I may treat that patient, with the exception of someone that may have history of a filter or history of a prior some kind of iliofemoral type or IVC type thrombosis. On the typical patient, in fact, I'll say, let's give them anticoagulation, and I may not even image them unless I think I'm going to intervene, because the ultrasound may tell me, I'm going for the symptoms, and I really guide it on the symptoms. I'm curious if you guys do that. Other than getting an ultrasound, I really don't do any other cross-sectional imaging until I've decided I may treat that patient because of symptoms.
Yeah, I won't do axial imaging unless they're symptomatic and I'm thinking about taking them for a procedure because it may alter what I do. I would say it's very rare you're going to see an acute IVC occlusion that's not symptomatic. So most of those do get intervention, or, if the common iliac down is completely occluded, it would be odd for them not to be symptomatic if that's acute. So usually those patients are getting intervention. I appreciate the point that it's not about the imaging, it's about the symptoms. But if someone has a complete iliac down occlusion and they're asymptomatic, you would really have to question the acuity of that.
All right, now let me get down to this. Just in your own experience, what percentage of the time do you, for iliofemoral DVT, we've already decided FemPop in general we're not doing. What percentage of the time for iliofemoral DVT do you think you wind up intervening? Tino, what would you say in your practice?
In our practice, I would say it's probably about 60 to 70%, something like that.
So iliofemoral, 60 to 70%, you're intervening.
Iliofemoral, correct.
Ron?
I think it depends on which ones are coming to my presentation or I'm being consulted on. So I don't necessarily, because of our specialty in interventional radiology, we may not get every referral of every iliofemoral DVT to our practice, while the vascular medicine physicians in my group may. And so my percentage may be a little higher of the iliofemorals that present to me. They've already been pre-screened. So mine may be more 70, 75%.
All right, so let's go to the vascular medicine guy. So Chris, in Ohio Health, of the DVTs that come through there, iliofemorals, what percentage do you think wind up getting some procedure?
I think 80% of patients who have clot above the inguinal ligament. And I think that number's gone up since we started doing mechanical thrombectomy, which we can do, we know we can do safely.
Yeah.
Because before it would be less, not because we didn't think they needed it, but because they just weren't candidates for lytic therapy.
Well, also because of the things that Kelly brought up from the beginning, is that. And Kelly, what would you say in yours? So we're talking like 70 to 80% here for iliofemoral.
Yeah, and I would say it's a little hard for me to parse out because we get so many femoral popliteals that we just simply don't. But I would say it's probably more in the 50 to 60% range.
All right, but at least for our listeners, we're talking about certainly greater than 50% and maybe somewhere around 70, 75% for iliofemoral if we average out everybody here. So it is more often than not that you are going to intervene, and the timing, as we said, is going to be based upon the patient's symptoms. And so in summary, tell me if I'm right here, and you guys correct me if I'm wrong, because we want everybody to take away something from this. In general, femoral popliteal, we're not considering intervention. In general, probably for iliofemorals, you just heard the percentages, you are considering intervention. Most patients get a time period, unless they're so urgent they have phlegmasia, get the time period of 24 hours, 36 hours, whatever, see how they do symptom-wise, and also they're ambulated or whatever to see how they're going to do. So it's rarely an emergency. Sometimes it becomes urgent if their symptoms increase. But the point is, in general, you're going to treat the patient. You're not going to treat the image. And that's really, one of the main takeaways from here is you still need to speak to the patient, find out how they're doing, and give them a trial run of anticoagulation and getting up, moving around, and see how they do. I've got to tell you, I'm actually surprised with the data that you guys just said in all your experience that it's that high in terms of intervention. But listen, there's 5 of you here, so, and you all do it. So that's another thing to take away. Everybody's listening. More than 50% of the time, people probably are being intervened upon. Anything I missed in the narrow roundtable? We could go on and on to the next step of what do you choose and stuff like that, but that's for another time.
Steve, I want to mention one point, and that is that I think now in the ER, when they see all these patients because of oral anticoagulants, a lot of these patients will go and get treated with oral and sent home. And I still think there's a lot of people we miss there that they need to know that if they have symptoms or they still have their symptoms after 24, 48 hours, they need to have somehow to get back so that they can be seen and then put back in the system. I think, 10 years ago, we caught all those patients. And now there's a lot of patients that they may come up to see us 2 or 3 months later, and it's too late to treat.
I think that's a great point. I
wanted to echo that as well. We say how many percentage of patients or what's the percentage we're taking for procedure, but I mean, Mechanical thrombectomy is an hour, but post-thrombotic syndrome is forever. And if you have those patients in your office, you feel helpless when you just can't do a whole lot for them up to a point. And if you miss that window, that's what they're left with forever.
Yeah, I think that's an excellent point that we need to, and we try at our hospital to tell the ER people that you need to call somebody, even if no one's going to do anything. You need to have us on board so we can follow up, not as you said, weeks later, but maybe, a week later or less than that to see how the patients are doing. So yeah, this has been great. This is exactly what we wanted. You guys kept to the script. We didn't go outside of this little narrow roundtable. And I hope, I think everybody can take something away from this. So we thank everybody for listening to Venus Edge and the narrow roundtable, and stay tuned for some other things. Maybe we'll have everybody back here and go to the next step. What do you use to intervene? And we'll take it from there. So once again, thank all of you for being here.
Thank you.